Now, it's time to meet the experts. Here to give us all a basic understanding of what cancer immunotherapy is and how it works is Dr. Jennifer Wargo, a professor of genomic medicine and surgical oncology at the University of Texas MD Anderson Cancer Center in Houston. There, she is focused on understanding why some patients respond to immunotherapy while others do not, with the goal of discovering how to improve responses and save more lives. As you listen to Dr. Wargo, feel free to drop your questions for her in the Q&A box. So let's learn together. Dr. Wargo, welcome.
Thank you, Tamron, and thank you to the CRI for the opportunity to share our insights on immunotherapy. And I think we can all agree we've made tremendous progress in cancer treatment with the use of immunotherapy and other strategies like targeted therapy. And I show some examples here of patients who had really profound responses. You can see on the left here, there was a patient with melanoma that had throughout the body, was treated with targeted therapy, and those lesions basically disappeared within 2 weeks. Immunotherapy is even more profound. I think we've certainly treated a lot of patients who come in with large established cancers, which can actually regress completely with the use of immunotherapy. So we'll talk a little bit more about how that happens. And so, how does immunotherapy work? And this will give you the basics of an immune response and a little bit of a primer on immunotherapy, if you will. And so, our immune system is really composed of a lot of different components. Certainly, there's barrier surfaces like nose and skin. There's also lymphatics, both lymphatic vessels and nodes, as well as tonsils and spleen. And then there's other components which actually can help with production and storage of immune cells, including the thymus, the bone marrow, and the blood. And really, if you think about it, an immune response is generated after either wounding or infection, but the same principles apply to the development of cancer. And so we know when someone gets a wound, there's a really essentially an invasion that's sensed, and immune cells go to that site. Those immune cells then begin to destroy and ingest the invader, if you will, in this case, a microbe. And some of the immune cells can actually transform into antigen presenting cells that can tell other cells to sense the invader. And so they're basically, this leads to the recruitment and activation of immune cells within the innate and adaptive arms of the immune system. These are essentially two different types of immunity. One is kind of your first soldiers who come in and will kind of clean up things, but then also prime it for a more adaptive immune response with B cells and T cells. And so, what about T cells? Well, T cells actually help promote long term immunity. These are a type of white blood cells, and these specifically promote long term immunity against antigens. And essentially, these require two signals for activation. So, in the context of this T cell, you have these two signals. One is where you have a T cell receptor and an antigen, which is actually on the major histocompatibility complex of the other cell, or MHC, and that's the signal one, if you will. And then there's a second signal, which actually promotes activation, and this is a co-stimulatory signal. And by having both these signals, you can actually really activate T cells. And what happens then? Well, following activation, there's an initial expansion where you get an expansion of these antigen-specific T cells, but you later get contraction of the T cell repertoire with formation of immunologic memory. And so you can see those blue T cells are actually memory T cells, and they then can kind of hang out and wait for another stimulation with antigen. Now, how about immune checkpoints? What are they, and what is their role in cancer, and how can we block them to effectively treat cancer? And so if you think about it, once you get this immune response revved up, you actually need to downregulate it. And this involves the use of immune checkpoint molecules in both the lymphoid tissues and other tissues. And this is where things like CTLA4 come into play. And so after stimulating an immune response, you don't want to have all these T cells floating around the body. So you actually have to downregulate that immune response after you successfully fought an infection. And so that engagement with that CTLA4 can actually do that. And that's at the level of the lymph node. In addition to this, at the level of the tissue, you have additional molecules like PD-1 and PD-L1, which can actually downregulate an immune response. And really interestingly, these ligands for the inhibitory molecules are often expressed and hijacked in cancer. And so, importantly, these immune checkpoint molecules that downregulate an immune response can actually be blocked using antibodies as anti-cancer drugs. We know these immune cells in our body can not only fight infection, they can fight cancer, but these tumor cells can shut them down with those inhibitory molecules. But now investigators have actually come up with antibodies that can block those interactions, and we'll talk a little bit more about that. And immunotherapy is now being widely used to treat many different types of cancer. And this form of therapy was awarded the Nobel Prize in 2018, including to Dr. Jim Allison, who's at the MD Anderson Cancer Center. And now many, many different tumor types are really being treated quite successfully using immunotherapy. Now, how about some other ways that we can use immune cells to fight cancer? And so we'll talk a little bit about adoptive cell therapy, about chimeric antigen receptors, some oncolytic viruses, and cancer vaccines. And so what is cell therapy? Well, we know that in our bodies, we have these immune cells which can potentially fight cancer. But when we have an established cancer, we know that these immune cells are not working perfectly. So what we can actually do is take these immune cells out, put them in a dish and activate these immune cells, grow them to large numbers, and then we can expand them again, and then potentially with the potential to reinfuse them into the body to help really help cancers regress. And so the first types of therapy using this have been including tumor infiltrating lymphocytes, where you can actually remove a tumor from a patient, grow out these immune cells to large numbers, stimulate them with T cell growth factors, and then put them back into patients. In addition to this, there are other strategies that are being used, and this includes CAR T cell immunotherapy, which stands for chimeric antigen receptors. And basically what investigators have done is they've been able to take a T cell and engineer a special receptor onto that T cell to make it easier to find different types of cancer cells and much more effective in treating these types of cancers. And so how does CAR T therapy work? We know that cancer cells, again, harbor antigens in the context of this major histocompatibility complex, or MHC. That chimeric antigen receptor in yellow, you can actually see, can recognize that antigen in the context of that MHC and actually cause destruction of the cancer cell. Now, what is oncolytic virus therapy? And so we know that some of the cancers that we treat sometimes are pretty resistant to treatment with immunotherapy. So how can we potentially sensitize these? And so what we can do is that, when we know that a tumor looks foreign, it can be recognized by the immune system. And so sometimes you can actually inject a virus, an engineered virus, into a tumor and actually make it more visible to the immune system. And that's exactly what oncolytic virus immunotherapy does. When this virus is injected, the cancer cell can actually die. Then these antigens are actually released into the tumor microenvironment and picked up by these special antigen presenting cells like dendritic cells, which can then process and present these onto the MHC and then can actually prime killer T cells to help fight against this. Now, how about cancer vaccines? And so we know that in addition to using oncolytic virus therapy and adoptive cell therapy, we can now actually engineer cancer vaccines. And how do we do this? Well, we need to know what the antigen is and know these tumor markers, which can actually be then engineered and actually injected and potentially can be used to help really make cancer regress. But these are earlier days with regard to the cancer vaccines, though we're making great progress. And what is the impact of this? Well, I think there's living proof that these therapies can work. On the left there, you see Sharon Belvin, who's an amazing individual, really one of the first people to be treated with anti-CTLA-4 by Jed Wolchuk and Jim Allison. And had a brilliant response and is alive and well and is just really a champion of cancer immunotherapy. In fact, she joined Jim Allison in Stockholm when he won the Nobel Prize. In addition, many of us are familiar with the story of Emily Whitehead, who had acute lymphoblastic leukemia and was diagnosed with that and underwent treatment with CAR T therapy quite successfully, although did have some toxicity, which was treated by Carl June and others, and is a real success story for CAR T therapy. And now we're seeing many, many more people benefit. And so the proof is here. Now, what are some other strategies that we can actually use to improve immunity and immunotherapy response? And here I'll talk about some new areas. This is the role of the microbiome and diet in cancer treatment. And so we know that cancer growth and response to therapy depends on a number of different factors. Certainly, if someone has a cancer, a tumor, it does matter what the tumor genetics look like. And so we know that the actual tumor genetics and the epigenetics also matter with regard to the tumor. We also know that other factors within that tumors aren't just balls of cancer cells. You also have other types of cells, and they can actually influence whether or not cancer develops and how it responds to treatment. In addition to this, we know that the immune system is very powerful and systemic immunity can play a major role. And then furthermore, there are other factors like environmental factors, such as the microbiome, that can actually profoundly impact cancer development and therapy response. And so what is the microbiome? And so here's an interesting little tidbit. So about 3.5 billion years ago, microbes, including bacteria, viruses, and fungi, actually helped shape the earth for future forms of life. It actually gave us the very oxygen that we breathe today. And 3.5 billion years later, it's now very clear that microbes are pervasive in our environment and even within living organisms. And advances in next generation sequencing have allowed us to better understand these microbes. And if you take an individual, if you consider an individual, there's around 20,000 human genes within an individual, which represents only 1% of the total genomic content. But there's between 2 and 20 million microbial genes in an individual, and this represents 99% of the total genomic content. And importantly, these are inherently modifiable. We can change these, right? And one big question here is, how does the microbiome influence immunity? Because immunity is really the cornerstone of immunotherapy response, and particularly the gut microbiome. We know that of those many, many microbes in our body, a lot of these microbes actually are sitting in our gut. And so, interestingly, our immune systems originally evolved to fight invading pathogens, but we know now that the microbes in our bodies can actually shape our immune responses, and particularly those in the gut. If you think about that long alimentary tract or our GI tract, on one side you have this dense network of microbes, again, including bacteria, viruses, and fungi, and other microbes. And just on the other side, you have this network of infiltrating immune cells in the gut. And so there's this constant and dynamic interaction between the two, and education of the immune cells by these gut microbes. And so it goes without saying that these microbes could have a profound impact on our physiology, our immunity, and on immunotherapy response. And what's the role of the gut microbiome in disease, and particularly cancer? Well, we know that disturbances of the gut microbiome, or dysbiosis, are now implicated in a large number of diseases. This includes things like colon cancer, inflammatory bowel disease, heart disease, depression, even things like asthma, diabetes, and obesity. But it also includes cancer. And we know that disruptions in the gut microbiome can not only lead to cancer development, but also can impair cancer therapy response. And I pose the question, could the microbiome become the newest frontier in cancer therapy with diagnostic and therapeutic strategies targeting the microbiome? And there's some evidence for this, right? And a couple of years ago, there were 3 papers published in Science, which really galvanized this concept that the microbiome could become really a major player in cancer treatment. And so at MD Anderson, we studied oral and gut or fecal microbiome samples in a large group of patients who were being treated for metastatic melanoma with systemic therapy. And I show kind of the schema of how we enlisted the help of these patients to really understand the role of the gut microbiome. And so when patients came to us and were going on to systemic therapy, we would actually ask them to sign on to a research protocol. And if they agreed, we would sign them up and then do an initial oral swab as well as a gut microbiome sample where we'd give them a kit so they could collect a fecal microbiome sample and send it back. We would do a tumor biopsy if feasible and then start their treatment and then actually look at the impact of the gut microbiome on treatment. And you can see that many of these patients who had melanoma were treated with immune checkpoint blockade, and most of them were treated with anti-PD-1. And so we really focused on that first. And so what we did is we actually sequenced the microbiome and we actually looked at the immune system, both at the level of the tumor as well as at the level of the blood. And what we found was really striking. We found that if patients who responded to the treatment actually had a more diverse gut microbiome, which is generally associated with better overall gut health, if you will. And not only that, they actually had different bugs in their gut with a higher abundance of things like Clostridiales, Faecalibacteria, and Ruminococcaceae. Whereas patients who failed to respond to the treatment had a higher abundance of different bugs in their gut, like Bacteroides. Now, with these findings, we and others have now, many people have shown that the gut microbiome can actually potentially predict response to treatment. A big question is, can we actually modulate the gut microbiome to enhance responses to immunotherapy? And how could you potentially do this? Well, certainly one way to do this is by a fecal microbiota transplant or an FMT, where you can actually take an entire gut microbiome complement and give it to someone else. Okay. And this is being used for C. diff colitis and other approaches, but is now being used for cancer. In addition, you could use administration of microbial consortia or probiotics. Also, I think diet and supplements or prebiotics is a tractable strategy to change the microbiome. And finally, you can target detrimental microbes maybe by antibiotics and novel technologies like phage. And there is some evidence that treatment with, believe it or not, fecal transplant can actually help patients on cancer immunotherapy. And so there were 2 papers that were published in Science that showed that in 2 independent cohorts of patients with melanoma that had spread throughout the body, that if they actually gave those patients a fecal transplant from either a patient who had a complete response to prior treatment with immunotherapy or even a partial response, they could actually induce a response in those patients and actually could reduce toxicity as well. Now, how about the role of diet and other factors on immunotherapy response? Certainly, fecal transplant is one way to do it, but can we actually either use diet alone or can we use diet in conjunction with other gut microbiome modulation strategies to enhance immunotherapy response? And we know that microbes in the gut are influenced by a number of features that include diet, antibiotics, and environmental factors. We know that physical activity, different diets, environmental exposures, antibiotics, and other factors can influence this. We also know that if patients get broad spectrum antibiotics before starting on treatment with immunotherapy, that there have been multiple studies now that show that they have worse outcomes, suggesting that if you disrupt that gut microbiome with broad spectrum antibiotics and then give immunotherapy, it's less effective. And finally, we also have seen some evidence that over-the-counter probiotics may not help immunotherapy response, they may actually harm it, though not all probiotics have been carefully tested. And we did actually at MD Anderson, we studied the role of diet and found that patients who reported more dietary fiber intake had better outcomes on treatment with immunotherapy. And so again, we studied a cohort of patients who were treated with immunotherapy for melanoma. And what we found is that if they reported sufficient dietary fiber intake of at least 20 grams per day, they actually had much better outcomes on treatment. And importantly, it's not a threshold, meaning that more is more. So for every 5-gram increase in fiber per day, they actually had a 30% reduction in the risk that the cancer came back. And we also looked at probiotics in this, and we found that if patients had a high fiber diet and they actually took probiotics, over-the-counter probiotics, they didn't do quite as well. And so it's really important to facilitate the gut microbiome. And based on this work, we and others are now testing diet as a precision intervention in cancer with the hypothesis that a whole foods-based fiber-rich diet can actually improve outcomes on cancer immunotherapy. And so Jen McQuaid and Carrie Daniel are working on this. They have this diet and immune effects trial where we actually have a bionutrition research core that actually cooks food for patients. And we give up to 50 grams of fiber per day. And what does 50 grams of fiber per day look like? Well, I include a chart here. You can see that lentils are fiber rich, black beans, lima beans, chickpeas, chia seeds. But you can see that some of those intuitively high in fiber foods, such as apples, are not quite as high as you might think. It only has 4 grams in an apple with the skin on. And so you have to really be intentional about fiber intake. But I think this is a very useful resource. And I think ultimately we need to embrace a more holistic approach to cancer treatment where we integrate monitoring and modulating the gut microbiome, diet, and other factors that include physical activity, sleep, stress, and other variables, because it really does all matter. And so with that, I will say, we can help address all of these issues on a global scale and also as individuals. So if you think about it, the choices that we make every day have a tremendous impact on our microbiome and our physiology, and they also have an impact on our planet. So, there have been a lot of people who have been, eating heavy meat diet, have a lot of inflammation, and the planet has suffered because of it. In addition, though, can we actually shift our focus, go to a more plant-based diet, and actually promote the health of our planet as well as ourselves in the meantime? And so with that, I'd like to close and thank you for your attention.
Dr. Wargo, thank you so much for that introduction to the fundamentals on cancer immunotherapy. A lot of science underpins today's treatments of all the various types you walked us through. I feel everyone watching this now feels empowered or is a little bit smarter about what immunotherapy is, and perhaps will be better armed to understand what it is when they're discussing these options with their healthcare team, as well as the need to advocate for themselves if needed. So much to go over. So we had questions submitted to us at the time folks were registering for today's event. Those of you who have been dropping questions in the Q&A box, we'll try to get to those as well. But why don't we just hop right in, Dr. Wargo? First of all, since we ended on the topic of the microbiome, I think you did give some advice on what people might want to do in order to improve their chances of responding to immunotherapy with the amount of fiber. Is there anything else that someone can do about that microbiome? How concerned should people be?
Yeah, no, that's a great question. I think there's a lot that we still don't know about the microbiome. And so I think, we know that at least from limited studies, we know that actually having a high fiber diet can actually help your microbiome functionally, so that it could potentially respond a bit better to cancer immunotherapy. We also know, things not to do. So I think, advocating a healthy diet that includes high fiber is reasonable, but everyone, who's contemplating that should certainly speak to their treatment team about that. And we are actually doing, again, dietary intervention studies where we go up to 20 to 50 grams per day of fiber, and so I think that's, really interesting. We're seeing some very interesting findings and promising findings. But I think, again, people need to work with their treatment teams. We also know that there are things that can harm the microbiome that actually could potentially hurt response to cancer treatment. That includes things like broad spectrum antibiotics. So I think, if people get, maybe a cold or something in the context and they're just about to go on to immunotherapy, rather than running to their primary doctor and asking for antibiotics, really talking with their oncology team and even raising the issue that, hey, I heard that antibiotics may actually harm my response to immunotherapy. I'm going on that, is this indicated? antibiotics are sometimes absolutely necessary, but I think it's really worth kind of thinking about it critically and mentioning it to your treating team. And then the over-the-counter probiotics, I think, sometimes really people want to take things into their own hands, and think, well, gosh, the gut microbiome is so important. Maybe I should just go out, and buy a probiotic off the shelf. And honestly, our data would suggest that that's probably not a good idea, and that really, eating a balanced diet with adequate fiber, if not high fiber, avoiding antibiotics, avoiding probiotics. And then all the, kind of common sense things like, try to reduce stress, try to get sleep. It's hard, right? These things are not easy to do. But I think, when you're embarking onto cancer treatment, these are things that you can potentially control. And if you can, it feels good and empowering to be able to take some things into your own hands and really help stack the deck in your favor. And you can derive benefit from it with stress reduction, getting more sleep, really improving social connectedness. Things like that can really help.
Good to know those things that are within our control. Anything like that can help. Here's another question. What do we know about the effectiveness of immunotherapy in pediatric patients or children and very young adults? Are there different side effects or different benefits seen in children that are different from adults?
Yeah, no, that's a great question. I think these are still being studied, regarding immune checkpoint blockade and CAR T therapy, and certainly there are a lot of children who have been treated with that. They haven't necessarily been compared carefully head to head with adult patients, but people are starting to do that, and I think it's a really interesting question. I think, again, a lot of variables go into really every individual, and that's, age, but also medications, antibiotics, things like that. And so taking everything into consideration, optimizing what you can, and being aware of other factors that might impact response to cancer treatment and toxicity is really important. But I think that's a great question. We don't have all the answers to that one yet.
On a related topic, then, someone or more than one individual had written in expressing concern about having some form of autoimmune disease and whether or not that would impact their eligibility or potential response, good or bad, to immunotherapy. What do we know about
Right.
that?
Yeah, that's a great question, and people are actually doing studies. It can be safely done, but I think you need to be with a treatment team that's very used to doing this. There are groups that are actually studying this in clinical trials to actually be able to use immunotherapy in the context, when someone has autoimmune disease. It can be done, but you should go to someone who specializes in this. And interestingly, some of the medications that are used in autoimmunity, such as anti-IL-6, are actually now being used, at least in clinical trials, in combination with immune checkpoint blockade in hopes to reduce toxicity and may even improve response, at least in preclinical models. So I think there might be some synergy. The short answer is certainly there is some pause when patients have autoimmunity that giving immune checkpoint blockade could create flares, et cetera. But if you go to a team that's used to treating this and can be aware of early insights and early markers, if you will, of autoimmunity, I think that's really key, and be able to treat it early.
Thank you. That's very helpful. Another group of questions centered around rare cancers. And so the questions are basically what kind of immunotherapy research is being done for rare cancers? And some of them that have been mentioned specifically include adenoid cystic carcinoma, salivary gland cancer, and fibrolamellar cancer, which is a form of liver cancer, among others.
Right. Yeah. And I think this is really important. Very important area of investigation. I know at MD Anderson Cancer Center, there's an actual rare tumor initiative where we're looking at these rare tumors in response to immunotherapy. There's also global efforts looking at this, and I think, again, it's harder with the rare tumors to get those large numbers, but I think we are getting insight. Things like Merkel cell carcinoma, relatively rare tumor, exquisitely sensitive to treatment with immunotherapy, but not all patients, right? And so trying to really learn from every patient to be able to communicate, with each other and share insights and really move the needle.
Thank you. We know, and you've said this before, that everyone's case is unique. Every patient is unique, and so their treatment is going to be unique. But this was an interesting question around a patient receiving pembrolizumab. The doctor's prescribing it based on her weight, so giving a dosage of 2 milligrams per kilogram every 6 weeks instead of, I guess, what's on the label or what Merck considers a standard approach of a dosage amount over a time period rather than based on weight. What do we know about weight-based dosage with immunotherapy?
Yeah, so I think again, this is one of those areas where patients really need to communicate with their provider. There's I think there's definitely a lot to learn still about different dose and route of administration as we really are treating patients with even FDA approved agents. And so I think there could be some rationale to it, but I think it needs to be better studied, really.
Another question that we have from one of our registrants, one of our attendees: what is the difference between genomic sequencing and genetic testing? Are they both the same? Are they both important? And should I be asking my doctor for those tests?
Right. No, great question. And so genetic testing generally looks at germline, which, so in our bodies, we have, kind of our host cells, right? Our germline cells that are kind of can dictate risk for cancer development, like BRCA1 and BRCA2, some other types of genetic markers that can put us at increased risk for cancer. And certainly it's worth discussing genetic testing, especially if there's a strong family history of cancer. Now, what's genomic testing? And so when you think about a cancer itself, these cancers actually can arise for multiple different reasons: exposures, genetic risk, other factors, like smoking, UV light for exposures. And then they get these inherited or not inherited, but somatic mutations or spontaneous mutations because of those different exposures or different influences. And that's when we're talking about genomic testing, right? Because that's when we actually look at the genetic makeup of that tumor, which is very different than our germline, really kind of our germline testing, if you will. And so I think both are useful. I think looking at the genomic testing within a tumor gives you some insight as to, are there these driver mutations that, pop up in this tumor and aren't present in the germline, that you could actually target things like BRAF and melanoma. You can actually take a pill twice a day, that can actually make tumors shrink but they often come back. And so I think it's one of these areas where ultimately it's going to be combination strategies for many patients, at least with tumors that are cold, if you will, or not, exquisitely sensitive to treatment with immunotherapy. We need to hit it from multiple angles. And that can include, doing genomic testing on the tumor, targeting mutations, and also treating with immunotherapy. And then I think, one other aspect of genomic testing is total mutational burden, or TMB, within tumors. And basically, that number can actually give us insight into the likelihood of response to immunotherapy. We know that the more mutations a cancer has, the more likely it is to respond to cancer treatment. And why is that? It's because the cancer looks more, very different from the normal cell, right? And so the more foreign a cell looks, the more likely it is that the immune system is going to reject it. And that's why we use things like oncolytic viruses. We try and make these tumors look very different to the immune system and have them rejected when we treat them with immunotherapy.
Well, thanks for that. That answered the next question I was going to pose to you. So I'll move on to another that is very interesting. Of course, COVID is still top of mind for a lot of people, and especially for cancer patients, many of whom may be immunocompromised due to whatever treatments they're receiving. And for them, risk of any sort of infection is always higher, and COVID really brought that to the fore. But a number of registrants noted that they, as cancer patients, are receiving immunotherapy and have been reluctant to get a COVID vaccine because they can't seem to get an answer from their healthcare team or drug manufacturer about any potential interactions between those two. Have you seen anything? Is there any reason for concern?
Yeah, well, I think with immunosuppressed patients, certainly they're at higher risk for COVID. And, honestly, the vaccines can help provide pretty good protection. I think it might not be as optimal in an immunosuppressed patient getting the vaccine, but it's better than not getting the vaccine, that's for sure. And, again, I think it's one of those scenarios where people really need to talk with their treatment team to make sure it's appropriate in their particular scenario. Have they just gotten myeloablative chemotherapy or something else? I think those are important considerations to take into account. But generally speaking, getting a COVID vaccine is the right thing to do. Interestingly, there is just recent literature that suggests that antibiotics and disruption of the gut microbiome can actually impair your immune system and can actually make COVID worse. So again, I think linked with the microbiome. So, we're actually studying in our at MD Anderson, looking at the giving a high fiber diet and seeing whether or not response to flu vaccine and other vaccines like SARS-CoV-2 vaccine can actually be improved with a high fiber diet. So I think still a lot to learn, but I think we're getting a lot of insights, and the bottom line is there are a lot of things that patients can do for themselves to really improve their overall health and immune system and really kind of stack the deck with regard to potentially being able to respond to these very promising forms of cancer treatment.
That's great. And that's all the time we have for audience submitted questions. But Dr. Wargo, before you go, is there anything else you'd like to say to the patients or caregivers who are encountering cancer for the first time, or if they've been on a cancer journey for some time, might be encountering immunotherapy for the first time or clinical trials?
Yeah, no, I think, just want to say, there's great hope. And I think, really believe. I think believe in your team, believe in yourself, really do as much as you can to, really hopefully help your body be healthy and respond to the treatment better, and also try to enjoy every day, right? I think that's really important for us all to embrace, as humans. But I think Cancer Research Institute, others are doing a phenomenal job at promoting research and really developing the next therapies, but the existing ones are pretty good, and there's a lot of ways that we can improve our own likelihood of really getting benefit from that. And we're also, I think, looking at ways to prevent cancer altogether.
Really fascinating and amazing stuff. So good for so many patients and so much potential to be better for even more. So thank you again, Dr. Wargo, for joining us for the 2022 Cancer Research Institute Virtual Immunotherapy Patient Summit. And also, I would like to thank the University of Texas MD Anderson Cancer Center for graciously co-hosting this event with us as an institutional partner. Thank you both again, and we look forward to more coming to you from the 2022 CRI Virtual Immunotherapy Patient Summit.